Okay, we're ready to pick up where we left off from the previous voiceover. So we are in that section on page 568 entitled Cardiac Cycle. And this first question that I'd like to pose to you, why is blood flow poorest in coronary arteries and cardiac veins during ventricular contraction? Remember, the coronary arteries are delivering oxygenated blood to the heart itself, while the cardiac veins are removing oxygen poor blood from the heart and eventually dumping it into the right atrium. If you think about these blood vessels on the surface of the heart, they're going to be most dilated, or the smooth muscle relaxed, during the time at which the ventricles are in relaxation. When the ventricles contract, when there's muscle contraction of the heart, that squeezes on those blood vessels and pushes blood through them. So it's sort of counterintuitive. You would think that maybe blood flow would be best through these blood vessels during the time in which the heart is contracting, but it's just the opposite. It's when the heart is relaxing that blood fills in those vessels, and when the ventricles contract, both right and left, that causes the blood vessels to become squeezed, and therefore blood is ejected from those vessels. So just something kind of interesting to think about. This is a picture of the heart after which a radioactive dye has been injected. This is a human heart, and as a result of the injection of this radioactive dye, we can see both the coronary arteries and probably even some of the cardiac veins, although most of what's shown here appears to be coronary arteries. And you can see again some of the larger, more prominent coronary arteries here, right and left, and then the various branches that extend inward, feeding primarily right and left ventricle, although I'm sure the atria also are fed to some extent too, but it's primarily ventricles, right? When you think about your heart, most of what your heart is made up of is the right and left ventricles. And so we do these angiograms when we suspect that there may be some partial or even complete blockage of some of these blood vessels. So if a person is, say, very winded or is exhibiting pain in the upper chest, where angina we sometimes call it, could be an indication of a potential heart attack, either going to happen or actually even happening, or it may be just indicating a future cardiac episode where, again, if there's a blockage, let's say where I'm drawing here in blue, we would be able to see that as diminished blood flow in these areas sort of downstream of the blockage. So angiograms are very useful for cardiologists to look at the heart and specifically address, is there any deficiency in blood flow going to the muscles of the right and left ventricles? Here we see where that very process has begun to play out. This is a partial occlusion of a blood vessel. We can see again there isn't any white there, so the radioactive dye is not being picked up. And as a result, there's been diminished blood flow in those blood vessels downstream, if you will, of the blockage. Even though you can see the white in here, this may actually be indicating some significant diminished blood flow. So what we want to do is we want to get in there and try to alleviate that blockage, try to remove it, try to open up the lumen. And that process is done as a procedure referred to as angioplasty. And I put a YouTube video here in the course content section of chapter 15, so you can watch that short video on angioplasty and stenting, and they'll talk more about how they open that up in a structure called a stent placed in to hold that lumen open. So I'm not going to talk about that right now, but you go in and please watch that video. So when we talk about the heart and its actions, we need to remember that we have four chambers: the upper superior pair of atria and the lower inferior pair of ventricles. Again, with the right and left ventricles making up the majority of what you and I would consider when we look at a cow heart or a sheep heart or a human heart, because the atria are much smaller in size. And we're going to be talking about atrial contraction and ventricular contraction and atrial relaxation and ventricular relaxation. And so we're going to introduce at this point in time a set of terms, the first of which is this word called systole. That's how you pronounce that, systole. Systole is another word for contraction. Okay, so if I talk about atrial systole or ventricular systole, I'm talking about contraction of those chambers. We also have another term, of course, you see up here. This is pronounced diastole, which is just a fancy name for relaxation. So ventricular diastole is describing relaxation of the ventricles, atrial diastole, relaxation of the atria. So don't let those words throw you. Just remember, systole equals contraction, diastole equals relaxation. So in this diagram we see in the lower left-hand corner of the slide, we note that the AV valves, which you should be familiar with now that we talked about in the first voiceover, both the tricuspid here on the right and the bicuspid here on the left are open. And as the arrow indicates, we have blood moving from the right atrium into the right ventricle and from the left atrium into the left ventricle. Okay, so we talk about the atria both in the process of systole, right? If the atria are contracting, i.e. in systole, what are the ventricles doing? Well, as you can see from the slide, the ventricles are relaxing. They're in diastole, both the left and the right. So as again, blood comes in from the atria through those two atrioventricular valves, the ventricles are filling, they're relaxing, they're undergoing diastole. In the next diagram in the lower right-hand corner, we have now atrial diastole, which occurs at that next step in time. So the atria, both right and left, are relaxing, while the ventricles, both right and left, are contracting. They're in systole. So we sort of reverse roles, don't we? So here we have the blood now being ejected out of the ventricles. Here we are coming out of the left ventricle through the aortic semilunar valve into the aorta. And on the right side, we have blood being ejected from the right ventricle through the pulmonary semilunar valve into the pulmonary trunk, which remember splits into the left and right pulmonary arteries, taking the blood, the oxygen, poor blood to the lungs to be oxygenated. The opening and closing of any of these valves, be they the two AV valves, tri and bicuspid, or the two semilunar valves, pulmonary and aortic, the opening of any valve is due to pressure changes, right? If the pressure, for example, in the right-hand diagram here, if the pressure in the ventricle, let's say right ventricle here, is exceeding the pressure in the right atrium, that's going to cause the tricuspid valve to snap shut. And remember, the chordae tendineae attached to the papillary muscles here, which are attached in turn to the valves of the tricuspid valve, when the right ventricle contracts, we talked in the previous PowerPoint voiceover how the chordae tendineae prevent prolapsing of the valve back into the atrium. Okay, so this snaps nice and shut when the ventricle contracts and undergoes systole. When we repeat the process in the next part of the cardiac cycle, which is going to occur over here, then the atrial pressures will exceed the ventricular pressures and the two AV valves will open up. So again, what determines when a valve opens and closes is based upon the pressures on either side of the valve. If the pressure is higher on the atrial side than it is on the ventricle side, the AV valve opens up. If the pressure in the ventricular side is higher than the atrial side, that AV valve will close. Now, of course, as the AV valve closes, what happens to the semilunar valves? Well, they're opening up, aren't they? So again, you got to understand where there are pressure changes on either side of the valve determines when those valves open up and or close. This is a video that I'd like you to watch, which will again review what we talked about and also introduce something called the ECG or EKG electrocardiogram, which we're going to get into in a few moments. So I would watch this video now, and then I would watch it again after we've talked about the ECG. It's a really nice video.
A single cardiac cycle is made up of the events associated with...
I'm not going to play that. You can play it. Okay, so here we are, of course, looking at the heart. We, I think, looked at this diagram in the previous voiceover. This just simply relates the position of the heart relative to the sternum and the thoracic cage. But what this is introducing are particular areas here, as circled, that we would place our stethoscope to listen for these different heart sounds. And you've all heard of the characteristic lub-dub associated with the beating of the heart. If we were doing this in person in lab, I would be passing out stethoscopes and we would actually be listening to our hearts and by placing the diaphragm of the stethoscope at these different areas and listening for specific sounds. Well, it turns out the first sound here, the lub portion of the sequence, lub-dub, we could detect that if we placed our stethoscope down here in the tricuspid and bicuspid or mitral areas, in which case we would hear the closure of the AV valves. Okay, so when the ventricles are in systole, those tri and bicuspid valves snap shut, and we would hear that as a lub sound, a first of the two sound sequence of a heartbeat. If we placed our stethoscope diaphragm up here in the pulmonary and aortic areas, which of course are near the semilunar valves, we would hear this second heart sound called the dup portion. This would occur when the semilunar valves snap shut. Okay, so these heart sounds are due to closure of the heart valves. The first sound, closure of the AVs. Second sound, closure of the semilunars. So a physician, trained cardiologist, by listening to the heart, can get a sense of whether there's any regurgitation or prolapse, for example, of an AV valve. They would be able to hear that. They diagnose that. After listening to thousands of people's hearts, you get pretty good at listening for abnormalities. So it's a kind of a neat, non-invasive way of evaluating potential heart issues with respect to valves. Okay, let's talk about the cardiac conduction system, which was again alluded to in the video that I hope you watched earlier. This is also discussed in one of the other voiceover PowerPoints in the chapter. What I want to draw your attention to, first of all, is in the upper corner, I should say, chamber of the right atrium, is something called the SA node or sinoatrial node. That's what SA stands for, sinoatrial. This is affectionately referred to, as you can see here, as the pacemaker of the heart because it does set the pace. This is a special piece of tissue. It's part heart muscle, part nervous tissue that initiates and distributes electrical impulses. With every heartbeat, impulses are sent from this SA node. And they are initially sent down these fibers shown here in yellow. So we have some neural pathways that feed into the left atrium, as we can see here, and we have other atrial pathways that feed into the wall of the right atrium. Now, what do you think is going to happen to the atria if they become stimulated by the pacemaker? Well, the atria are going to undergo systole. They're going to contract. Okay, so again, the black arrows are showing the distribution of the impulses through both right and left atrial walls as they emanate from the sinoatrial node. And in response to that excitation, to that stimulation, the atria will contract. I want you to also pay attention to this second kind of somewhat oval structure at the base of the right atrium near the interatrial septum, and I'm going to circle that in black. This is referred to as the AV node. What do you think AV stands for? Well, you've heard of AV valve. AV is atrioventricular. So this is the atrioventricular node. This is again a special type of part cardiac muscle, part nervous tissue that is going to receive impulses from the SA node. As you can tell, some of these branching yellow structures are coming to the AV node. And what's interesting is these particular pathways, these nerve fibers called junctional fibers, they are quite small in diameter as they approach the AV node. And the reason for that, as indicated by the blue box here, is to delay transmission of the impulse. So there's a slight slowing down, if you will, of the impulses as they approach the AV bundle. And this is going to be important, the slowing down, if you will, because it's going to allow for the atria to ultimately contract before the ventricles do, and allow those ventricles to fill. So let's follow what happens to the impulses as they then leave the AV node. So here's our impulses. They arrive here. They then travel down a superior portion of the interventricular septum. This is sometimes called the AV bundle or bundle of His, this kind of superior portion of the interventricular septum. And then the pathways branch. As you can see here in green, we have a right and a left bundle branch, they call them. Right and left bundle branches. And let's just follow the right bundle branch. It's coming down the interventricular myocardium, and then it's going to make the turn at the apex, and then it's going to feed up into the papillary muscles, some of them, as well as into the myocardial layers here of the left, or I'm sorry, of the right ventricle. If we had followed the left bundle branch, as we will now, coming down the interventricular septum, it's going to come down, make the curve, and then travel up into, again, the walls of the left myocardium and also into some of the papillary muscles. Now these branches into the papillary muscles will terminate in what are referred to as Purkinje fibers. And you remember me talking about those in one of the earlier voiceovers, and I said we're going to come back and talk more about Purkinje fibers later. But here we are. These Purkinje fibers are going to eventually be the terminal sort of ending structures of our conduction system here in the heart. Purkinje fibers. Okay. In addition to extending into the papillary muscles, I want to also reiterate the fact that these Purkinje fibers also extend into the myocardial walls as well. Okay, it's not strictly papillary muscles, but also into the entire right and left ventricle walls. These Purkinje fibers take those impulses. So here we've got a flow chart of the pathway of impulses as they originate here, of course, here in the pacemaker, in the upper superior portion of the right atrium. This is the sinoatrial node, the pacemaker. And then we travel through both right and left atrial walls. This is referred to as the atrial syncytium, this kind of collective arrangement of these fibers as they innervate the walls of the right and left atria. And then we come to these junctional fibers, which remember are these smaller diameter fibers that lead to the AV node. And then we have the AV bundle at the superior part of the interventricular septum, which branch again into the right and left bundle branches, and ultimately, as we said a moment ago, into these Purkinje fibers that eventually take those impulses into the papillary muscles, as well as all parts of the myocardium of right and left ventricle. And those are, just like we said earlier with regard to atrial pathways, all of those feed into what's referred to as the ventricular syncytium. So let's watch this little video. See if we can play this. Can we play this? Maybe I can't play it. Okay, you're going to have to play it. It will talk about the cardiac pathways and relate it to contraction of both atria while the ventricles are relaxing. And remember, that's followed by ventricular systole while the atria are in diastole. So definitely watch this video, this animation. It will kind of pull together many of the topics we've been talking about for the last 30 minutes or so.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
Okay. Go back and watch that a couple times if you need to. This is showing the fact that when you look at the myocardium of the right and left ventricles, that the orientation of the cardiac muscle is oriented in what are referred to as whorls. It's kind of a funny word, whorls. In other words, the patterning is not necessarily just around the circumference of the heart. It's not horizontal, if you will, nor is it vertically oriented cardiac muscle. It's oriented in these concentric spiraling whorls, they're called. Now you have to understand that the contraction of both right and left ventricles begins here at the apex, and then that contraction works upwards as the black arrow is indicating. And that makes sense if you think about the pathway. Remember, the impulses pass down the interventricular septum, right and left bundle branches, down to the apex, and then the curving, if you will, of those pathways upward into the ventricular walls and into the papillary muscles. So that process of ventricular systole or ventricular contraction is going to begin at the apex and work upward superiorly. And what that basically does is it maximizes the ejection of blood out the ventricles during systole. It's somewhat analogous to you taking a rag, placing it into a bucket of water, lifting it out of the water. If I asked you, how could you maximize the amount of water out of that rag, you would all grab that rag and you would twist it, wouldn't you? Everybody would do that. Take that rag and you twist it and turn it until you get every drop of water out. Well, this is the same idea here. When the heart contracts, there is this sort of twisting, upward twisting motion from the apex up toward the atria. In the same way that you're twisting that rag, you're twisting the heart, if you will, because of the whorled arrangement of the cardiac muscle fibers. And that, again, is allowing for maximum ejection of blood into the aorta as well as into the pulmonary trunk. So that's kind of interesting. Okay, we alluded to the ECG 10-15 minutes ago, and one of those earlier videos introduced that concept. So after we get done talking about this, go back and watch that again. This stands for electrocardiogram. EKG is the older German abbreviation that actually is still used today to some extent. Same thing, ECG, EKG, electrocardiogram. So this is an electrical picture of what is taking place within the cardiac conduction pathway. And typically when you have an ECG done at the hospital, is they will place 12 leads on your chest and back, and those leads are designed to pick up minute electrical signatures that will culminate in the waveform you see up here on the top half of the slide. And again, we've all seen this before in TV shows and so forth. Each one of these, and I'm going to just circle one here, each one of these represents the electrical activities related to a heartbeat. So every heartbeat has an EKG or ECG. And again, had we been able to meet face to face, we would do a lab where I would hook you up not to 12 leads, but we would use a 4-lead system, and we would be able to record, and we'd actually do some measurement of some of these waveforms. And that's really fun to do, and I'm sorry we can't do that. But what is going on during an ECG? Well, let's define a few terms here before we get into the specifics of what takes place during a cardiac cycle. We need to introduce some terminology. And you'll be hearing about this in A&P2 when you get to the nervous system. So a little sneak preview. You'll be ahead of the game when you get to A&P2 because you will have heard these terms in A&P1. So the first term, depolarization, is technically an electrical process that occurs when there is a change in charge between the inside and the outside of a membrane. And typically we talk about that membrane being part of a muscle fiber or a nerve cell, a neuron. And it's due actually to the movement of a particular ion called sodium. And I think you've heard of sodium before. If you remember, we talked about sodium in flux at the neuromuscular junction, remember, in response to the acetylcholine coming into contact with the receptors on the folded sarcolemma. That in turn opened sodium gates, remember, sodium channels, and sodium flooded into the fiber, and that's what initiated the muscle impulse, remember, the muscle impulse. Well, it's the same idea here. When we have movement of sodium in, that causes electrical changes on the cell membrane, on the surface of the cell membrane, and we call that depolarization. If we restore the previous charge scenario before the sodium flooded in, which we would actually do, and we'll talk about that in a few moments, then we would use the term repolarization. So this is a restoration of the charge between the inside and the outside of the cell membrane. In this case, we're going to talk about cardiac muscle, but it could also be applied to neurons. And so when you see those two terms, just remember it's due to charge changes that take place across a cardiac muscle membrane due to sodium movement. We're going to be talking about depolarization leading to systole or contraction in the heart. And we're going to use the term repolarization to describe the events that lead to diastole or relaxation to the chambers of the heart. So let's take a look now at a picture of a heart, diagram of the heart. We'll look at the 4 chambers. You'll see those in just a moment. And we're going to follow the depolarization, which leads to systole, and the repolarization processes that lead to diastole or relaxation. Here we are. You see the heart diagram. You should all recognize the 2 atria here, right? Here's the 2 ventricles. Here's our aorta. Here's the pulmonary trunk. Here's the right and left pulmonary arteries. Okay, you all recognize those. Here's our SA node we talked about earlier in the upper superior chamber of the right atrium. Remember we talked about how those impulses that are initiated here and distributed from the SA node pass first through the wall of the right atrium, and then it will pass next into the wall of the left atrium. So let's let that play out. So here comes the yellow into the right atrial walls, over into the left atrial wall. Full depolarization of the 2 atria. That's depicted, isn't it, here on the EKG as something that's referred to here as the P wave. This little upward stroke of the pen, if you will, if it was connected to a piece of paper or a computer screen, you see a little upward movement. This is P wave. P wave is depolarization of the atria. Remember, this is electrical events, depolarization. This is not physical events, it's electrical events. So again, this process of depolarization of the atria, shown here in yellow, is going to lead to eventual atrial systole or contraction. Now, where do you think that yellow is going to go from here? Well, it's going to go to the AV bundle, which is going to be here somewhere, right? And then it's going to pass through the interventricular septum, the bundle of His, and then down into the left and right bundle of branches. Remember that? Go back and review those diagrams. And so the yellow, starting here at the apex, remember, and working upward, just like the contraction will be doing so in just a millisecond or two. But the depolarization begins in the deep portions here of the ventricles and works upwards. And so we're seeing that begin to occur here in yellow. And look what's happening in the atria. They're green. Green is representing repolarization. Okay, yellow is depolarization, green is repolarization. So during the time at which the ventricles are beginning to depolarize, the atria have repolarized. And we're seeing on the EKG the formation of what's referred to here as the QRS complex. This downward movement is Q, then we have a big spike up, that's R, comes back down, is S, now it's going to come back up. Let's complete that whole complex here in the next slide. And the next slide is going to show both ventricles fully depolarized, but you're going to see that the atria will go from green back to white. So the atria are going to be done. There we go. So here is the full complete depolarization of both ventricles. The atria are done repolarizing. So when we talk about QRS complex, the QRS complex is both depolarization of the ventricles and repolarization of the atria. Now, what have we yet to do? We've already depolarized the atria and repolarized them. We're done depolarizing the ventricles. There's one last thing we have to do in our cardiac pathway here, system, cardiac conduction system, and repolarize the ventricles. And now we're doing that. You can see the green beginning here toward the apex region, going to flow upward. We have full repolarization of the ventricles that will lead to relaxation or diastole, and that's going to be depicted and is on the EKG as what's called the T wave, this big upward flow of the pen. T wave is repolarization of the ventricles. Here we've got the previous few slides combined into one. This is again nice because we can take a look at what happens from the very beginning here of an ECG to the very end of the ECG. And so this would certainly be worth taking time and reviewing. Here we've got, again, a little bit larger sketch of two ECGs. You see again the various waveforms. Here's P wave. This is depolarization, remember, of the atria. Here's the QRS complex, which remember is what? This is two things: repolarization of the atria and depolarization of the ventricles. And then here's our T wave. And what did that represent? Repolarization of the ventricles, leading to relaxation. Had we done the ECG in lab, we would have, again, gathered several of these, and we would have looked for the different waveforms. We would have also spent some time looking at specific time intervals within the ECG. Our system that we would have used would have allowed us to actually measure those, and we would have compared them to expected normal values. So this so-called PR interval, which is really from the beginning of the P wave to the Q part of the QRS complex. I know it says PR, but it's doesn't go all the way to R, it goes to beginning of Q. Don't ask me why. That would be somewhere between 0.12 and 0.20 seconds. We would have also had the system measure the QRS interval, which would be from Q to where S comes back up and reaches what's called a baseline. This is the baseline right here. That should have been less than 0.12 seconds. And we would have also had the system measure the QT interval, which would be from the Q to where T comes down to a baseline. And that is our longest interval here, somewhere between 0.3 and 0.4 seconds. Now remember, this is less than half a second, isn't it? 0.5 is half a second. So these events, these EKG events, the depolarization, repolarization events of both atria and ventricles occurs very, very quickly, doesn't it? Yeah. So we're talking about, you know, an entire ECG taking less than, well, here's the beginning, here's the end. You know, we're talking about a little over 1.6, 1.7 seconds. And that makes sense because your heart rate's probably somewhere in the neighborhood of, you know, 65 to 72 beats per minute. Now, if we see this sort of ECG, this looks pretty weird, doesn't it? Not typically normal, at least it looks nothing like the ones we've looked at thus far. Here we have obviously something indicating a prolonged QRS complex. This should be close together, shouldn't it? But here we have a prolonged time frame here. This QRS is being pulled apart, if you will. And this could be, and often is, an indication that there's been damage done, maybe because of a heart attack, to the AV bundle fibers. Remember, these are carrying the impulses down the interventricular septum, right and left bundle branches, and then up into the walls of the left and right ventricles. So what I'm trying to get you to think about is when you see abnormal ECGs, and there's all sorts of different ways you can have abnormal ECGs. The trained cardiologist can look at that and get some idea if there's been some damage done to the heart, specifically to the pathways that these impulses must follow during each ECG, which again is taking place with each heartbeat. So the textbook for interpretation of ECGs is about half the thickness of your lecture book, believe it or not. It's really a thick textbook. So it's not easy, but again, cardiologists are trained to know what these different abnormal waveforms look like and what they mean from a clinical standpoint. See something like this if you're an EMT, for example. You've got the person hooked up to the EKG machine, and you see no recognizable P waves, QRS complexes, or T waves. The heart is in this kind of fluttering mode. This is referred to as fibrillation. The heart is fibrillating. It's literally quivering. If you could look at that heart from above, it would just be quivering. This is not good. You're going to die unless we can fix this. And I give you some potential causes of what could induce fibrillation in a heart. But you want to get this heart back into a more typical EKG rhythm, don't you? So how do we do that? How would you do that? Well, if you were at the hospital, these stimulator pads, right? You've seen the TV shows where they have the pads and they put the pads on the person's chest as they're laying on the gurney, and they say shock, and the guy jumps out of his hospital bed almost in relation to that, even though he's unconscious, he jumps. This is a little bit different, of course. Here we have somebody, let's say, who's had some heart surgery, and we want to kind of get that heart back into normal rhythm. They're putting these metal components here on either side of the ventricles and giving it a much lighter shock, if you will. That's going to get the heart back into the normal heartbeat rhythm. But either way, you want to stimulate the heart. And typically it will then kick in, so to speak, and you'll get back to that more typical ECG waveforms. Okay, I think that concludes this voiceover.